Okay, and then we just carry on with extraoral radiography. So as we've discussed before, the most common or the specialities that make use of extraoral radiographs the most tend to be orthodontists as well as oral and maxillofacial surgery. So essentially now, some of these skull films can be exposed with a standard intraoral radiographic machine, but most of these then require the use of an extraoral unit as well as a cephalostat. So you will encounter problems or challenges with these particular radiographs, but you will over time get used to them, ladies and gents, because initially it may be difficult to interpret them because of the numerous anatomical structures that exist in the area. Hence, it's very important to correlate the anatomy that you have learnt with what you see on an x-ray. I think if you put the two together, it will just make things slightly easier for you guys. Né? But sometimes you do, especially if you have positional or patient errors. They may affect your x-rays, and you find instances or situations where some of these structures appear superimposed over one another. Even in x-rays that do not that were done properly and they appear accordingly, you still find situations, because obviously an x-ray is a 2D representation of a 3D structure. As a result, you will find instances where now the structures will then appear superimposed over one another. So the most common radiographs that we will find in this instance would be our lateral cephs. We will find our posterior anterior projections as well as our TMJ projections. These are mainly or more commonly used by oral and maxillofacial surgeons. So with our lateral ceph projections, they are basically then used to evaluate facial growth and development, trauma, disease, as well as developmental abnormalities. So with these projections, they try to show the bones of the face and the skull, as well as the soft tissue profile of our patient. Okay, so it's essentially taken from the side, as the name basically explains to you guys, that it is a lateral cephalometric projection. Okay, so now this is essentially sort of what a ceph looks like. Yes, so we're seeing all the facial structures, a bit of the spine, of our C-spine, as well as soft tissue profile of our patient. And then from there, in terms of orthodontics, they make use of anatomical landmarks such as your pogonion, your menton, your ANS, your PNS, and other such anatomical landmarks. They join them together to actually then get all the appropriate measurements that they need, so that they can actually, how can I say this, develop or discuss or find out how the patient is growing in terms of their bones as well as their dentition. From there, we then discuss diagnostic records. So sometimes, especially with orthodontics, just to track the patient's growth, development before and after treatment, we may have to make use of photographs. As we've mentioned in all your previous videos, with photographs, you want to take frontal, you want to take lateral, as well as profile pictures of the patient. So these are then useful as aids in terms of patient identification. So you know whose records belong to whom, treatment planning, case presentation, especially if maybe you're a postgraduate student or even an undergraduate student, or discussing patients with your colleagues, for case documentation as well as patient education. So if you take pictures, especially if you're trying to intercept on a bad habit or trying to improve on a patient's oral hygiene, as well as education, you then actually try to make use of pictures, especially intraoral pictures, to try and stress the need for oral hygiene, especially if the patient is not necessarily all that compliant. So like I'm saying, here is examples of a lateral picture of a patient, as well as a profile or a frontal aspect or frontal picture of a patient for case documentation. And then from there, you can also even take intraoral pictures. So again, frontal view of the patient's teeth and occlusion. From there, we have the maxillary occlusal view of the patient, as well as the right buccal view of a patient. So these are just examples of the type of pictures you'd have to assist your dentist or your orthodontist in taking for case documentation, treatment planning, and case projection pictures. So from there, we will be taking panoramic radiographs. As you can see, the teeth are not too narrow, they're not too blurred, nothing's distorted, there aren't any objects that are causing ghost images, there aren't any lead aprons that are causing artifacts. So this is an example of a very, very beautiful resultant radiograph if the patient is cooperative and no errors are made. So essentially, like we mentioned before, even with our ortho presentations, cephalometric radiographs are essentially extraoral radiographs that make it possible for us, being dentists, orthodontists, as well as less commonly maxillofacial surgeons, to actually evaluate the anatomic basis for malocclusion, as well as the skull, bones, and the soft tissue, most commonly being the patient's soft tissue profile. So then from our cephalometric radiographs, we can make cephalometric analysis. So this is mainly done either by dentists that actually do orthodontic work or even orthodontists themselves. So essentially, with cephalometric analysis, this is the tracing or computerized drawing that involves a series of points that make it possible to compute a means of mathematical descriptions and measurements for the status of the skull, not just of the skull, but even of the patient's teeth. So this is an example of cephalometric landmarks. I don't want to go through them in detail. We have discussed them in our earlier orthodontic chapter or unit that we did a couple of weeks ago. So I'm just going to run through it. Again, we make use of certain landmarks anatomically. We then make the appropriate measurements or lines based on these landmarks. And then from there, they give us measurements that we can then interpret to help evaluate the status of the patient in terms of the patient's growth and development. So this is just an example of a patient's soft tissue profile. This would be typical of a class 2 division 2 patient. This would be typical of a class 3 patient on our right hand side. So those are some of the pictures that a dentist or a surgeon or specialist may actually ask you to assist in actually taking. And then from there, you can see in the next slide that they show you that the size of the nose and the chin tend to have a very profound effect on the relative lip prominence of a patient, because sometimes a soft tissue profile is actually deceiving. It may exaggerate what's happening in terms of the patient's facial structures, or sometimes, especially more in black patients, it may actually camouflage the severity of a patient's status in terms of their skull's growth as well as development. And then from there, the following slide then talks about the most important cephalometric measurements. I will not be going through these landmarks, ladies and gentlemen. We did them through our orthodontic presentations. So we'll be checking for our facial axis. So that would normally be from there all the way to our pogonion, and then from there SNA, SNB, A and B. So that is basically we're checking the relativity or the positioning of the maxilla relative to the mandible and so on and so forth, to actually see the type of class, the skeletal class of the patient. And then from there, our APO line, we also then evaluate the inclination of our incisors relative to the basis of the maxilla as well as the mandible. So we check the inclination of both our maxillary incisors as well as our mandibular incisors. We also then do the Witts appraisal just to further classify the patient skeletally. We then assess the patient's soft tissue as well as harmony line. So those are some of the things that we will evaluate based on our lateral ceph projections. And then from there we have cephalometric measurements. Again, we'll not necessarily be going through these because we have covered them in our ortho unit. So please revert back to our ortho unit. But if you have any questions, do not hesitate to ask me under the comment section. I will be more than happy to answer you. But in this example, especially on the right-hand side, they're just showing you the measurements that we normally do. If it's not computed, we actually measure them physically by making use of our ruler, HB pencil, as well as protractor. So here is 130 degrees. So that's just denoting the inclination of our maxillary incisors relative to our maxillary base, and then vice versa as well with the inclination of our mandibular incisors. And then from there, SNA, so SNA, SNB, A and B, which is essentially Steiner analysis. We try to classify the patient skeletally. Are you class 1, class 2, or class 3? So that would be in POG. So from our nasion all the way to point A, which is the most prominent structure on our maxilla, and then from point B, which is the most prominent structure or the deepest structure on the skeletal aspect of our chin. And then from there, the A and B is basically SNA minus SNB. We then get our ANB. So all of that is essentially just to classify the skeletal pattern of our patient in terms of their growth and direction. So These are then some of the landmarks that I was discussing with you guys. So that is point A, that we find 3 millimeters below A and S, and then point B, 3 millimeters above our pogonion relative to our nasion. So we take that for SNA and SNB, and then the difference between the two, so it is SNA minus SNB, giving you A and B to then give you the patient's skeletal classification. So those are all the points that we will be making use of to actually interpret the patient's growth and development. From there, okay, so this is just another slide of the visual treatment objective or growth forecast of the patient after taking the SEF, identifying all our landmarks and making the appropriate measurements. So from there, we can then diagnose our patient in terms of the patient's health. We would have done a thorough dental examination, both intraorally and extraorally. We have static models, so those are our study models that we had discussed as part of our fixed and removable prosthesis. Go back to those slides, ladies and gentlemen. X-rays that we are touching on right now, which are our external X-rays, being our pan X-rays, our SEF X-rays, even CBCTs, but we will not be delving into those for today. And then from there, our photographs intraorally as well as extraorally, our mounted costs wherever necessary, and then our cephalometric X-ray. So we take all of that and actually diagnose the patient. So we would be addressing the patient holistically, taking everything into consideration, the patient's profile, or the objectives we're trying to achieve, and so on and so forth in treating our patient. So this would be an example of a typical record keeping that you would find, especially at an orthodontic practice. We have our patient profile as well as lateral pictures, intraoral pictures. We have our patient's name. We have the practice. We have all the necessary dates when the pictures were taken. And then from there, we can start commencing with our treatment. From there, ladies and gentlemen, okay, they're just showing you all the types of points or landmarks that we're trying to achieve with our cephalometric analysis. So we want to make sure that we get the soft tissue profile, we get the hard bony landmarks from there. We have our upper centrals, our lower first molars. Some orthodontists go as far as even tracing their premolars, but in this example, they just did the first molars, upper and lower, as well as our central incisors, upper and lower, and then from there, all the anatomical landmarks. So that's essentially what you would see at the end of a tracing session. Hey, ladies and gentlemen, we have our posterior anterior projections. So these x-rays are basically used to evaluate the facial growth, development, trauma, disease, as well as any developmental abnormalities. So this projection shows the frontal and ethmoidal sinuses, the orbits, as well as the nasal cavities. So they've basically discussed what anatomically you would expect to see from a posterior anterior projection. So with the posterior anterior projection, ladies and gentlemen, you instruct the seated patient to hold the cassette next to his or her face and then rest it on his or her shoulders. And then from there, the X-ray tube head is positioned on the opposite side and directed so that the central X-ray is perpendicular to the patient's head as well as to the cassette, right? And then from there, the X-ray exposure time is increased because of the layers of tissue and the bone that obviously the X-ray tube head would have to go through in order to get to the cassette, okay? And then from there, the patient's head is positioned differently depending on the area of interest that the either the surgeon or the dentist would want to view or see, essentially. So that is basically how you'd position a patient for a posterior anterior skull projection.